these conditions present, right? So you do have to take into consideration the mechanism of injury, if it's an injury, take into consideration the patient's presentation and their complaints, right? Because you're treating the patient, but your lab test, certainly not your x-rays, right? For example, a patient that presents with vague foot pain, you take an x-ray and you notice what looks like either a sesamoid fracture, but you know that there could be a bipartite sesamoid, right? The patient is not tender at the base of the first metatarsal. What do you do? Non-tender, yes. This is not the source of the pain, but you notice this thing there, and you can't tell what it is, right? Say again?
Parts or the period?
No, so we're talking about what looks like a fracture at the base of the hip, a sesamoid fracture. So it's either sesamoid fracture or a bipartite sesamoid, right? That's the only thing that lives there. That's only besides the metatarsal head, right? So the question is, what do you do if a patient presents with foot pain, right? And you notice there's an incident of finding on your x-ray. So you suspect they've got something going on in the foot. You take an x-ray and you see this thing that looks like a fracture, but you're not sure. So you could redo your exam, okay? And if they're still non-tender, then what? Okay, so you say nothing. What do you say?
Check the other foot to see if it's on the side, and then.
So you could compare the contralateral side, okay? Anybody else?
Let them go.
So repeat your physical exam to see if you can reproduce the pain. Okay. So all of this, none of these answers are wrong, right? And this is the art of medicine. What you don't do though is go chasing things that, so you go order MRI and bone scans and so on and so forth, right? Because each one of these tests adds a cost to the patient, adds a cost to healthcare. If they're asymptomatic and that's not the reason for their complaint, then you don't go chasing it. Right? That's kind of like the moral of the story. But you can see how easy it is for you to get caught up because you see something and you want to find out exactly what that is. Right? Now, if it was symptomatic in that area, then certainly you want to, especially if that's the chief complaint, then you can continue on to find out what's going on. So this is where we go back to treating the patient, not what you see on the screen, not the lab results, not the x-ray. You see how easily you can get caught up in looking at something and you want to find out what it is, and the patient may see them like, what the hell is this? It looks like I have a broken foot, right? In spite of the fact that they're not tender in that area. Okay. So, many things present with less certainty than you would expect, and you know, we all teach you some things and we practice the way that we were taught, or the way that we learn things, you know, mistakes we made, we corrected them, and medicine has changed, so we're doing things different. And you will find when you do your practice, you're gonna do the same thing. Right? You learn some things here in phase 2, and then when you get on the ground, you realize that actually doesn't quite work as well. So you develop your own practice. All right. So we covered all of these things yesterday. Today we are going to go on to some pediatric conditions. The first thing we're going to talk about is the os trigonum. We talk about the accessory navicular bone. We talk about the calcaneal apophysitis. And all of these are just secondary growth centers or accessory ossicles that you'll see on x-ray, which will lead back to my opening question. When you find these things, if they're symptomatic or asymptomatic, what do you do with them, right? So some of them, they'll be there, they've been there for a while. They're just now presenting because they're causing the patient's pain. Right? If you have previous film, there's always advisable Go back and double check with historical terms. Okay, so the trigonal is an accessory article that you will find at the posterior aspect of the tibia, right above the calcaneus. These things may be present for quite a while, but they don't manifest until the patient tends to aggravate it. So how do you think that this accessory article, what activities could cause the patient pain? Anybody? Jumping, okay. You said plantar flexion. Come back to you in a second, right? So jumping, what else? Running, dancing, right? And so why plantar flexion? So there is, so you actually, yeah, right answer. There you go. All right. So you get impingement from all the activities that we talked about because of foot plantar flexors, right? And it seems, you know, well, this is pretty obvious. However, not until the patient starts getting into accelerated activities that cause repeated plantar flexion that this thing shows up. And normally it's within when they get to their teens, in cheerleading, if it's female, in football they start jumping, running, you know, playing all these other sports. If you see that as an incidental finding on X-ray, know that it's a normal variant. If it's asymptomatic, just leave it alone. Until the patient presents and they have some issues. So, if you see that, there is no reason for you to go chasing down this thing and referring them for specialty evaluation. Questions about that? And so with everything that you see on this slide is everything that we covered in the last couple of minutes. Now, just like if it becomes symptomatic, now you got to do something about it, right? And just like any other orthopedic exam, have the patient walk. Sometimes you can have them do things that will aggravate the symptoms because that actually helps narrow down your diagnosis. Give them some NSAIDs because it is a musculoskeletal injury and those respond very well to the NSAIDs. Always stop the offending activity. Sometimes physical therapy may or may not help, but it's a bony structure, it's an anatomic structure. And even though PT might help with strengthening, in a lot of cases, when all of that fails, then you refer them for specialty care. So what would we do with one of these things? Depends, right? In most cases, we just take it out. No harm, no foul to the patient. The accessory navicular bone is a similar presentation, right? In this case, this thing may be there for years before it shows up or before the patient complains about it. And that accessory navicular bone is always on the medial side of the foot, inside of the foot. Now, in some cases, patients get all the way into adulthood and this doesn't bother them at all. When they start getting into activities, then that's when this thing shows up. We talked about the posterior tendon yesterday, right? And its function in maintaining that medial longitudinal arch, right? This is one of the sites of attachment for that tendon. So you can imagine, as you continue to work out and jump and run, then continue to pull on that tendon, and so this thing gets a little more irritated. So, in cases, how would this present? Sometimes there may or may not be swelling, but what you always have is that little bump on the side of the foot. Patients have presented with an accessory navicular, not because it hurts, but because there is a bump on the side of my foot and I just don't know what it is. And in some cases, if it's a little mobile, they keep on playing with it and then it just gets irritated. In other cases, that little bump may affect them because of the type of shoes that they wear, so it keeps on running against them. What test would you do to reproduce the pain of an accessory individual? Think of the foot, think of what, well, you could direct palpation, yes, right? What does the posterior tib tendon do? Invert or invert? Oh, that, talked about this yesterday. Well, it does maintain a medial longitudinal arch, but what else does it do to the foot? Inverts the foot, right? I have to reteach this lecture from yesterday. You guys will sleep. Maybe. Okay, so it inverts the foot, right? So you reproduce that motion, and sometimes it will reproduce the pain that the patient is feeling. And that goes for any other orthopedic exam you do. If you want to find out whether or not a particular motion, right, causes a patient pain, try reproducing the motion. Sometimes they let you, sometimes they won't. And because the posterior tib tendon is very instrumental in maintaining that medial longitudinal arch, if that becomes a problem, they may end up with best practices, right? So you see how the two things between our lectures yesterday and this lecture today, right? I've told you time and time again that you should always take weight-bearing films of the foot if you're trying to figure out what's happening. Some cases you may need to get a non-weight-bearing film, but certainly weight-bearing films of the foot as much as you can, right? We always go for 3 views, AP, lateral, and oblique. We talk about some other things with the ankle where you do a mortise view, but that's when we start talking fractures. So, the AP view is the best view for you to see or visualize the accessory navicular bone. Questions or comments? So how do you treat these things? Same, right? Always, if you can, when you're looking at issues with the foot, observe how the patient ambulates. And sometimes you can do that, just watch them walk to your clinic, right? See them walking across the parking lot. They may have crutches, limping on the wrong foot, all kinds of crazy nonsense, right? They walk with their crutches in the hand, and when they get into the clinic, then they can hardly bear weight. It's crazy the things that soldiers do. But for those that have true pathology, you can just tell as they walk towards the clinic how the extent of the injuries. Okay? In your clinic, however, just ask them to take a few steps and see how they react. Right? And then you do the same thing that we talked about. You observe it, palpate it, make sure you try to reproduce the pain and range of motion. Physical therapy may or may not help in these cases, but PT is your best friend, always. Right? Now you can offload those pressure points by using orthotics, right? And these orthotics could be anything from the orthotic pads all the way up to having some special arch supports, right, for the foot to maintain that medial longitudinal arch. If this is one of those cases where if a patient has repeated injury to that area, right, and especially if you do an MRI or a bone scan or something like this, just based on the patient's presentation, and they have repeated microfractures, then we put them in a cast. Remember, that's a little bone tendon attached to it. It affects how the patients walk. It affects how they do all their daily activities, especially if they're into sports. So that workup might be a little more extensive. Right? When all of that fails, then do what you do best and you refer them to ortho. you really can't go wrong. You can't go wrong with referring and asking for help, right? Does it make sense? Like no one will ever sue you for seeking guidance or counsel from a fellow clinician. Now we might call you and ask you what they're going to be doing, right? But you'll get over that piece, right? It is when you don't, then it becomes a problem, right? Or if you don't document some of your findings. So, here's a TTP for you. If you're taking care of patients in the clinic and you're just not sure, right? Just call someone. I can't tell you, even now, I still call people. I call my friends, I call the ortho surgeons, sometimes I call primary care based on what I'm doing, right? Just call someone. There are very few fellow clinicians that will give you crap because you go out and ask for second opinion, right, or some advice on what to do. Later on, I'll tell you a story of one of my near misses in the ER. Story for another time. All right. Okay, any questions about this? And so understand that this could be very disabling because of where it is and what the posterior tip does. Yes, sir. Yes and no. So in some cases we will remove the ossicle. And remember that tendon has more than one attachment, right? It's a broad-based attachment. If it's only attached to the ossicle, which is probably not likely, then we just anchor down the rest of the tendon with screws here. So, essentially what we'll do in cases like this is probably make some channels inside of the navicular bone, right? You suture the end of the tendon, run them through the tunnel, and then you just tie it down. And these things are strong. You would rip the bone before you pop the sutures. That's a good question. All right. Anything else? Let's talk about Sever's disease, calcaneal fasciitis. It's a little different in the sense that it is an unfused growth plate, right? And so we talked about the attachment of the Achilles tendon on the posterior calcaneus, right? What we didn't talk about, and I don't recall mentioning it, is how far down. You'll be amazed at how far down that attachment is, right? Most people think it's at the top of the calcaneus, but it's not. Right? And so it's attached to that secondary, that ossification segment. Sometimes that just doesn't fuse as the patient grows. And so they get into activities that requires repeated jumping or plantar flexion of the foot, right? Especially when they start very early. And if you have repeated microfractures, right here in that area, then you can see as you have these microfractures, the body deposits additional bone just to heal, right? And then this thing just gets worse and worse. Almost similar to osteoarthritis. You guys covered that, right? So, normally those patients would present with pain, right, at that site. Very classic because there aren't too many things that live at the posterior aspect of the calcaneus. You got the Achilles tendon and you got the heel bone, right? The heel pad is absolutely essential for weight bearing, right? Segue for a second. This little area at the bottom, right here, absolutely essential for weight bearing, and there isn't a whole lot of extra tissue in that area. So when these things are happening, patients have a lot of pain, significant amount of pain with weight bearing. Right? So those of you who are old enough to remember, like right around the start of the global war on terror, so we had a lot of folks were getting blown up, right, because of the newly placed IEDs or going through the tanks, right? You guys remember this? No? Right. Wrong population. But so we get a lot of fractured Achilles, right? another case, but calcaneus. And so after we repair them, you could take something that is absolutely shattered and you could put it back together and make it look like a bone. But it was still painful because they lost the key pads. And so at the time, the Center for the Intrepid, which is right next to Barnsley, was just starting up, and we had folks that were going there for rehab. These guys would look at folks with prosthetics running around playing basketball. That's when we just started doing this stuff. And ask for amputation because it was so painful for them to walk. Yeah. Devastating to see them just present like, look, I would rather have a prosthetic than my good foot that I can't walk on. To give you the extent of, how much pain these guys with patients with. All right, enough segue. So you get repeated stress and traction, right, on that apophysitis, and it just continues to irritate the patient and continues to pull away. Okay. In a lot of cases, this thing will fuse by the time patients get into their preteens, right? Don't pay much attention to 11 versus 13 years because it varies so much with the patient's puberty. But by the time they get to the preteens, all of those ossification centers should start fusing. And when they don't, then they have continued pain because that's about the time that these guys or patients really start getting into sports. High school sports, getting into college sports, or preparing for college sports, right? And so, classic presentation, pain in the area, pain with activity, pain with weight bearing. What's a common thing to all of this? It's pain, right? Your exam should mimic everything that we talked about when you do an orthopedic exam. You watch them walk, okay? You try to reproduce the pain, direct palpation, and that should give you high index of suspicion, especially if you do that heel squeeze and it is painful. So, you can take some plain films. Sometimes it gives you a good indication of what's happening, and sometimes it does not. Because unfused ossification centers generally show up the same way in X-rays, right? If you don't know the patient's age and you see this, it doesn't really tell you much, right? And most times it does not look fractured, it just looks like there is something there. But you should have a high index of suspicion if the patient is painful, if they're tender when they do this, if they have pain with weight bearing, and then you see this on X-ray. Make sense? Okay. In some cases, you might see a little bit of extra bone deposition as the patient continues to weight bear and irritate this area. Okay. This whitening that you see at the margins called sclerosis, that's an indication that there is additional deposition of bone, right, as this thing tries to heal. If you find it on one side only, right, because remember both heels have an apophysitis, right? They have a secondary growth center. So if you find it on one side, then you might start questioning your diagnosis and start looking at other things, okay, to include bone cysts or even fractures. How do we treat these? Same, right? Watch the patients ambulate, and I'm repeating these things for a reason, right? Always watch them ambulate. Always look at the thing that you're treating. If a patient presents with these types of symptoms and you do not have them take their shoes off, you are 100% wrong. You do not do an orthopedic exam without direct visualization of whatever it is that you're looking for, the body part. Now, PT may or may not help because in some cases we can rest them and have them strengthen the gastroesophageal complex, which forms the Achilles tendon. Right? You can try shoe modifications, and those you can actually get from the orthotic shop, right? Send them to the brace shop, and they'll have custom orthotics made for them. When it's really bad, then of course we can do some Achilles tendon stretching and put them in a cast. Put them in a cast depends. If it's tender for them to stretch to 90 degrees, they're not going to tolerate the cast. Make sense? And so there may be some serial casting that might have to do with these patients. In 9 out of 10 cases, most cases, this thing will heal well with non-operative management. However, even if surgery is not indicated for this, if they fail non-operative management, you still refer them to ortho. Right. Questions about these ossification centers? Last couple of classes, let's talk about clubfoot. The last few classes we discussed the different arches in the foot, right? We paid a lot of attention to the medial longitudinal arch. What happens when that arch is exaggerated, right? We call that a cavus foot. Origins from cave, right? Now, if you have a cavus foot that is excessively dorsiflexed, what's the other word that we talk about? We say that the foot is in, I'm sorry, not dorsiflexed, planiflexed, right? It's in equinus, right? Okay. So let's kind of peel back the onions in this for a second. You've got a cavus foot that is in equinus, right? Okay. What if it's inverted? Is that possible?
Yeah.
Right? It's getting there. And so a club foot is a cavus foot that is planiflexed, is in equinus, and inverted. And in some cases, a lot of cases, it's also invirus, which means that when you look at the heel bone is also shifted inwards. Right? Guys tracking that? It's important for you at this point to understand the mechanics of a cavus foot. As we go into this, you'll see why the foot is oriented the way that it is, and then what you can do about it. All right. So, pes cavus is what you consider an excessively high arch, as you just saw in the picture. If that foot is in virus, it's called a cavovirus foot. And if the foot is in equinus, then it's called an equinal cavovirus foot. And because it's related to the foot, then the condition is called talipes equinal cavovirus. In a lot of kids, this can be either due to a neurological or a neuromuscular problem, right? Condition. Probably say in most, right? Some cases it's progressive. It can be unilateral, it could be bilateral. In cases where it's associated with either a variant of spina bifida, and you guys know from, have you guys done neurology yet? Okay, so you know that spina bifida is a constellation of different conditions, right? You guys talk about that? When you hear spina bifida, because there is spina bifida occulta, there's, you can, the word itself is not just a condition, right? So there are different types of spina bifida. Okay. We need to revisit that. I'm saying afterwards. So if it's due to a spinal cord problem, right? Spinal bifida being one of them, then you have to, sometimes you can correct the underlying condition first. However, in most equine parvovirus foot, then you simply treat the condition and try to correct it. So based on the age of the patient, this can absolutely be corrected. Okay. Charcot-Marie-Tooth disease, which is a hereditary condition, usually some patients with that condition also. We'll talk about this a little later as well, right? Usually presents with clubfoot swelling. So, the main problem that patients have with clubfoot is they can't wear adequate footwear, right? And you see the orientation of the foot, so that tells you why footwear can be an issue, right? Why would these patients have pain at the metatarsal heads? Exactly, same thing we talked about 2 classes ago, right? Remember when I told you if you got a patient with metatarsalgia, you don't put them in high heels? Kind of like the same principle, because their weight is now shifted more distally. So that normal weight distribution that you would have with the tailors distributing the weight between the calcaneus and the midfoot, that's gone, right? And now the vast majority of the weight is on the foot. Pain in the plantar fascia, right? I think that's pretty explanatory as to why we discussed that again yesterday. Because we talked about what the plantar fascia does to maintaining the medial longitudinal arch, right? So now you've got that arch which is exacerbated, or so what I'm looking for. It's a higher arch. Right? I remember the word tomorrow and I'll bring that. But right? So if that arch is extended, then you're going to have more problems with the arch of the foot. Now, would you expect these patients, as they continue to ambulate, especially when they get older, right? Would you expect them to have problems with their palaces, hammer toe, right, floor toe, etc., right? In Africa a few years ago, where these are not readily corrected when kids are teens, and this older guy, probably in his late 30s-ish. I mean, the extent of injury, secondary injury to his forefoot was just amazing. So all under his hammer toes, every last one of them was just these thick calluses. Right? And his entire right foot, which is the other unilateral foot. So his entire right foot, that his toes were just filled with plantar calluses. Very thick. We tried to tear them down and do something to them, but got to the point that it was just too much. Very debilitating for some patients. Okay. So when you do your physical exam or your H&P, always make sure you look for neuromuscular diseases and sort of family history. Right? If you can get back to their birth history, right, and see what was done for them at birth. Sometimes we ask that you do a neurologic assessment, so have them go to neuro, right, and get that done. And when all else fails, you know they have to go through a process, right? If it's a young kid that you're seeing in the clinic, they have to go through a process for correcting this. Some of it can be corrected in the clinic, some of it you have to send to ortho for. If you have an opportunity to take some plain films are great. We do try to measure some of the angles in the foot. We look at the Mary angle, which is that angle between the axis of the talus and the first metatarsal. Don't worry, this is not a math class. I will not test you on what the Mary angle means, but it's good for you to know. Right? And again, you want to make sure you take PA and lateral radiographs of weight-bearing radiographs of the foot and take a look at the lumbar spine. Why do you want to take spinal films? Just talk about it. Huh? Yes, exactly. Right. Because some of these things are not always caught, especially in rural populations. How many go out there? Any confidence? Okay. So some of these things are not caught as readily as they should in the most rural population. If you're active duty and you're out, doing humanitarian work, you may end up having to take care of some of these right here in the United States. How do we treat these? Well, most times the treatment can be non-operative, and with non-operative management, you can get fairly decent results. But it all depends on what the underlying disorder is, right? So, through modifications, some rehab, strengthening, looking at range of motion, those all do well. But, based on the age at which you catch this, the non-operative management may not work. So, I don't have an age distribution for you, but just understand that if non-operative management fails, then they will need some tendon transfers and other orthopedic interventions. The reason why you want to get these into neuro is because if they have a neuromuscular disorder, neuro can help as well. We just talked about what a club foot would look like, right? So if you look at that foot, you will see that it is not only inverted, it's got a high arch, it's plantar flex, which means that it is inclinus. Okay. And I think on one of my other diagrams I have, you notice the angle of the calcaneus relative to the tibia, right? This relatively normal. This is not normal. Yes? Okay. Yes. And so with the heel pointed inwards like this, look at your top left picture. With the heel pointed inwards, same as the one on the bottom right, that foot is in virus. Does it make sense? Any questions about this? What if a patient had a valgus foot? Right? So here they have a high arch, right? In a valgus foot, how would you describe that? Right, and it looks more like this. So what's that condition called? So what? Pes planus, flat feet, right? Don't move the fingers. Pes planus. So a varus foot, you have a higher arch, right? A valgus foot, you have a flat arch. Okay. One way to remember Talipes equinovirus is looking at all the components of it, is using the acronym CAVE, right? C-A-V-E. Right? We started off talking about the cavus foot, which is a high arch. The foot is in adduction, right? And it's pointed inwards. You've got the heel in virus, which we just talked about, is the adduction of the calcaneus. And because it's in plantar flexion, then it's in equinus, right? Those are the components of the cavus foot. Notice that in club foot, there is no mention of an adducted foot, right? Everything is adduction, adduction. So, in some cases, this is idiopathic, so there is no real reason, or you can't identify a reason for it. But if it's positional and flexible, then it's more amenable to non-operative management. If it's due to a neuromuscular disease, right, a meningocele, a myelomeningocele, or even arthrogryposis, who knows what that is? Did you guys cover that in neuro? So this is a condition in which various joints of the body are in excess of deformity, right? In a lot of cases, you'll find that at the shoulder joint, it's adducted, right? The shoulders might be rotated a little forward, right? One of both legs might be adducted and externally rotated. And then at the foot, you get a callus foot. So you can see, I haven't seen one in real practice, but as we learn it and we see pictures of patients with it, it looks very, very, very deformed. It's kind of saggy actually. Right? So it's widespread deformity of major joints in the body. And in the vast majority of cases, you will see an arthrogrypotic foot looking something like this. Okay, so clinical symptoms. If they are infants, right? If they are infants, that deformity may or may not present with initial physical limitations, right? But in a lot of cases, they may, and mom or dad may identify that deformity, especially when the kid is either not weight bearing or attempting to weight bear and can't weight on the extremity. Right? There may be some gait disturbances, difficulty wearing shoes, and kids they may just complain of pain overall. Okay? Always do a comprehensive physical exam. I just told you. You have to get neuro involved early if you suspect it, and even if you just have a low index of suspicion, but involve them early anyway. Right? There is a standardized measure for calculating the cavity of the foot, right? When you measure between zeros and ones, total score of 6. Beyond the scope of this class, but if you have the time, just look at that. Okay? And then you just annotate that in your records. If pediatrics or neuro or ortho, will always be willing to help you with this. Again, plain films, AP, lateral, in most cases you might want to run a bleed. Now, in some cases, you may not even need these films to make a diagnosis, right? However, in children that have residual problems, deformities, then you might want to get some X-rays to see the extent of the injury. If you find yourself working in a rural area where this was never caught, then certainly you want to get some X-rays to continue to document the progress of the patient. So, remember I told you never just take an X-ray willy-nilly because you don't know what you're treating, right? This is an exception where if a patient presents to you late and you're going to start some treatment, you take X-rays just to document your starting point. Does that make sense? And as you take serial X-rays, then you have something to compare it to. If these never get treated, right, as the guy that I was telling you about from Africa, right, there is all sorts of problems, right? There is a social stigma because even that guy, and I mean, that lived in a village, people kind of looked down on him, so he was always dirty and so on and so forth. They have problems wearing shoes, and You know, it's just a lot of, it's not a good thing with patients, right? Like medical conditions, social conditions, pain with weight bearing, can't do things that they want to do. And I imagine some depression is setting in or something. However, you know, we're fortunate to have decent medicine here in the United States. And so there are a lot of orthotics that we can do and a lot of corrective things that we can do for these patients. How do you treat a clubfoot in a patient? Okay, if the patient is young enough, we use something called the Ponseti method. All that is, right, and that's after you've done all your other physical exams and so on, right? It's serial casting where they get casted once, initial cast, right, with the foot in its original orientation, and then serial corrective actions each week until you get the foot straight. Sometimes we add what we call a tenotomy, which is just a small incision into the Achilles tendon to allow the foot to move. Okay? So there's also tendon lengthening, where you actually cut the tendon and lengthen the tendon in such a way that, you know, it's not tugging on that part of the foot. What I want you to know about is that non-operative management for the pediatric clubfoot Ponseti method, serial casting. Now, after casting, right, if you do nothing, what happens? It's going to go right back to its deformed orientation, right? Therefore, very important, right, that after casting, you put the patient in a foot abduction brace for about 3 months, right? And then they continue wearing this thing for about 3 years. And even after all this, there's still a 30% recurrence rate. However, right, for all the positive Nancy's in it, that means there's a 60% success rate, right? 70%. Did I say this on the math class? So that 30% is based on the literature, right? It kind of varies, but average overall. So the recurrence rate, what this is saying is that the recurrence rate is lower than your success rate, right? So it is worth trying this method, the Ponseti method. Yes, sir.
What stage, how often after can we start the like Ponseti, like almost immediately, or do we have to wait like 6 months time before we start?
Yeah, I don't know. I have not seen a less than 3-month-old doing this. I'll find out for you from my pediatric ortho people. It's a good question. I don't know the answer for you right now. If I forget, if you forget things, just remind me. Okay. Now, whenever you put a cast on, there are certain things that you have to remember. When we get into fractures, we'll talk more about it. But improper casting is always bad. Okay? You can't actually get compartment syndrome from improperly applying a cast or split. And improper casting will certainly worsen this thing. So if you notice cast number 1, you notice the level of deformity in cast number 1, right? If you try to correct it, as you see in cast number 3, on the first week, that's a problem, right? So you're probably wondering, does this hurt the patient? There is some discomfort, but the goal is not that this is excessively painful for the patient. Thankfully, kids don't know what, maybe 3 months-ish, very pliable and very flexible, so that makes this very amenable to non-operative management. Questions about that? All right, we have been the most attentive audience, which means we deserve a break. Come back at the top of the hour. For pediatric clubfoot, non-operative management, consenting method, serial casting, over 5 weeks, right? And when you're done with the casting, you absolutely have to do the abduction brace, right? Because if you don't, you just wasted, but you won't optimize the treatment plan. No point in going into the different procedures that we do for operative management, but just understand that there are ways that we can get to this to give these patients a better outcome and lifestyle. Yes, ma'am.
Is the 30% assuming compliance?
So it's a good question, right? The question is the 30% assuming perfect compliance? Maybe not perfect, but compliance with the bracing, yes, right? And so, like anything else, like the success of your treatment plan all depends on how well the patient does what you ask them to do, right? How many of you in here have gone to the doctor, they gave you a treatment plan, and you're like, this doesn't make any sense, I'm just going to do my own thing? Yeah? Right? So we are, maybe nurses make the most patients. Do you have any nurses in here? One? Raise your hand if you're a nurse. That's okay. I understand that you want to, okay, you see? So I think, in my opinion, this is just the gospel according to me, that nurses make the worst patients. All right? Yes. And then PAs are a close second. Doctors, they in there somewhere because they, okay, maybe I should follow, what that treatment is. Yeah, we generally do not take our own advice. And these nurses, they are the worst. Love them. Can't do without it. All right. Any questions about any of these topics? Yes, is the time to ask. Let's talk about pediatric test planners for a second. Right? So we talked about some things in the adult population, right? We talked about the pediatric clubfoot, which is a high arch condition. We talked about adduction being a component of that pediatric clubfoot, right? Are we going in the opposite direction? So, you will notice that most young kids, right, toddlers, as they grow, they have flat feet, right? You see a kid just starting to walk, unless they have a condition that predisposes them to a high arch, then you'll notice that they have some flat feet. Okay? So, in a lot of cases, test planners is a normal variant. If you look at folks that have grown up with flat feet, according to the data, upwards of 25 to 30% of the adult population continue to have flat feet throughout that adolescence and into adulthood, right? So the arch doesn't really start developing in kids until they're about 4 years. And by the time they get to like 10, 11, 12, and in their preteens, then they're starting to develop a very pronounceable arch, right? You will notice that young preteens that are heavily engaged in sports and wearing improper shoes tend to carry on that flat feet throughout their preteen and sometimes into their teen years, right? You will see that a lot into the young active duty recruits that are coming in. It is amazing how many of them come in with test plans. And you watch them running down the track, just foot slapping all the way, right? And you wonder why they can't run, right, and meet the timeline, because they have to work too hard with that push-off gait, right, because of their flat feet. So, the flexible flat foot is most common because it's correctable. You can use orthotics, as we talked about, to replace or to replicate or to support that medial longitudinal arch, the one that we keep on talking about from day one, right? in a rigid flat foot, it is a little more difficult for you to reproduce that arch. In a lot of cases, a flat foot is even asymptomatic. Patients don't even know better. They don't know that they have it because it's just been a part of their lives as they go on. Right? Pes planners could be unilateral or equally bilateral. When it's unilateral, sometimes it causes the patients a little more discomfort because it's more pronounced and it tends to bug them more that they have symptoms in one foot versus both. Okay. In the case of a rigid flat foot, which is a little less common than a flexible flat foot, then you have to start looking at what are the underlying causes. Could be idiopathic, which means it's just a normal variant based on that patient's genetics and how that patient grew up. Or you could have things like a tarsal coalition, a rotated, what we call a vertical talus, in which the talus is in the rotated 90 degrees or some variant up, right? Could be neuromuscular, muscular, or just some inflammatory condition, right? Now, during the first class, we talked about weight bearing and how that weight is distributed across the foot, right? You remember that? Okay. What did I tell you? Which bone bears the vast majority of your weight when you're standing? The talus, right? Talus, talus, potato, potato. My southern accent. You pick whichever one you want to use. Now, if for whatever reason you continue to gain weight, right? Continue stressing that medial longitudinal arch, what do you think is going to happen? Continues to drop, and it gets to the point where the structures which support the medial longitudinal arch, which are one and one. Posterior tib is one. What else? The plantar fascia is the other one, right? And there's some intrinsic muscles there, right? Just a quick check on learning. What are the bones that form that medial longitudinal arch? Raise your hands. I want to pick them. Yes.
Oh, the cuneiforms?
So the cuneiforms, right? The medial, intermediate, and the lateral cuneiforms, okay. Which one? Yeah, 1, 2, 3. Right? What else? The navicular, cuboid, put that in there. So that leaves us with 2 sets of bones. You're thinking, what is it? You're absolutely right. The calcaneus is one of them, right? Then what's the last set of bones that form the medial longitudinal arch? The metatarsal. All right. Guys, we're paying attention. So, if you continue to stress the medial longitudinal arch and all of those structures that support it can no longer compensate, now you've got a permanent flat foot, right? And so the more weight you put on it, more stress you put on it, right? That's why we have, obese population, most of them have problems with their feet. Okay. Just trying to share weight mechanics. So how do these patients present, right? Some of them may present with discomfort, some of them may not, right? We talked about our young recruits that are just slapping it all the way down the track, right? Come back and sweating like they ran a marathon. Because the increased work of running, right? Just trying to compensate for their anatomic deformity or mechanics, right? In some cases, you'll notice that there is some contracture of the Achilles tendon. I think we beat that horse to death. The importance of the Achilles tendon, right, in maintaining that proper alignment of the foot. However, if your foot continues to be flat, so to speak, right? Which means that the calf now has to compensate for your push-off gait, right? Or the push-off phase of walking, of your gait. And so that stretches the Achilles tendon. Then you've got the lengthened Achilles tendon and chronic calf pain, right? So, physical exam is exactly the same as you would for all musculoskeletal conditions. You must look at it, as the patient walk, right? You do things that would reproduce the patient's symptoms. You do not, under any circumstances, do an ortho exam with the patient's shoes, socks, clothes on, right? Always have a chaperone, right? Don't care if you're looking at the feet or the hands, as much as possible, have a chaperone. Man or woman, doesn't matter. Even if it's your friend, try to have a chaperone in there with you. Now, in cases where there is a loss of that medial longitudinal arch, sometimes you can measure it, right? In the old days, you would take a pencil and just roll it under the medial longitudinal arch to see how well that pencil moves, right? We talked about, in the case of posterior tib tendon dysfunction, right? What's that thing that you do when you look from posterior to anterior, looking at the alignment of the calcaneus to the forefoot? Too many toes sign, right? Very classic for PTTD, posterior tib tendon dysfunction, right? But that allows you to look at the orientation of the calcaneus and the hindfoot relative to the forefoot. Make sense? Did I lose anybody? Now, in a flat foot situation, remember that the forefoot is always abducted, right? As opposed to a club foot situation where it's abducted. Yes? Okay. So, you can try to, it's something called the jab toe test, and it works sometimes, sometimes it doesn't, right? You try to recreate the arch by having the patient stand on their toes. And the mechanism of how this will actually work is that if you've lost the medial longitudinal arch, right, because of weakened structures in the foot, if you stand on your toes, then that should recreate the arch, right? Some patients it does, some patients it doesn't. But it's just something to note for your clinical practice. Our treatment for this, like any other ortho condition, is if it's painful, try taking care of the pain, right? After you do your physical exam. So, NSAIDs, your best friend. You can add some, based on the extent of the injuries, do not jump immediately to narcotics, right? I think you have, even at your aid stations, you might have tramadol in your kit. If you have a benign, you might have Toradol, right? Toralac. You can use some of that. My cocktail for this is a gram of Tylenol and 800 of ibuprofen. That's going to keep severe pain, patients with severe pain off of narcotic pain meds. Okay. And if you do that every 8 hours, you're actually under the max dosage for both. One, as we talked about, is metabolized in the kidneys. The other one is metabolized in the liver. So you're generally safe. Be careful if they have hypertension. Some people respond differently. That kind of stuff, right? Okay. Physical therapy is great for some of these because they can help, right? They can actually assist in calf strengthening and posterior tib strengthening, soleus strengthening, and allow you to get some relief. Most times you find out that you have to do custom orthotic inserts, and again the brace shock can help with those. And be careful with how we do shoe recommendations. There are classes that you can take, right, that helps you with recommending the proper shoes for different patient populations. Outside the scope of this class, just understand that it's out there and you can take advantage of it. Now, what happens when all your non-operative management fails? Take a knee. So you don't get them surgery, but you do refer them to some specialty care. Right? Doesn't mean that you always do surgery. So, in cases where non-operative management fails, then you refer them. We may or may not do surgery, especially for a rigid flat foot. Sometimes that's the only way to correct it. When you start talking in class of correlation on these things, then it'll make more sense why we have to do some surgery to help correct some of these conditions. If you've got, so you're looking at the red flags that I've got up on the slide. If you've got contracture of the Achilles tendon and rigid flat foot, those are indications for referral. What do we do? Sometimes you can cut the heel bone, change some things around, do what we call an osteotomy, right? And to help recreate things for the patient. Metatarsus adductus, metatarsus abductus. Now you can find these, it says we have it here in the pediatrics, but it can also occur in adults as well, right? What is that? It is medial deviation of the forefoot. Medial deviation of the forefoot. As the name suggests, it has to do with the metatarsals, right? And the metatarsals are in the forefoot. This generally happens as a result of some repositioning in while the patient is in the uterus. In some cases, though, right, it may be due to some other neurological condition, right, or even some other musculoskeletal condition. You will notice in a lot of newborns or toddlers that the foot looks a little weird, right, and that's one of the reasons why parents bring them into the clinic. Okay? They can spontaneously resolve, but when it becomes a problem, right, especially if it becomes more pronounced as the patient grows, then we have to do something about it. Okay? As you see, it's associated with torticollis, tibial torsion, or even hip dysplasia. So what does that mean exactly? It means that if you see one of these patients in the clinic, then you have to start looking at what are the other associated conditions as part of your index of suspicion and your differential diagnosis, right? So, case problems that present to you, you should always start thinking, what else could be going wrong? Why this is the way it is? Right? Kids are resilient, they're very pliable, right? But they also have conditions that can exacerbate some of the conditions they present. And so you have to make sure that you're looking at those as well. What do you do on physical exam? Okay, like any other physical exam, the same thing. Look at it, you kick and walk, have them walk, you palpate, do range of motion, okay? You look at adduction of the foot, of the forefoot, relative to the hind foot. We talk about the concave foot, right? So you look at the convexity of the foot to see if that actually is playing into that adduction of the forefoot. In some cases, you may see that as the metatarsal adducts, right, it takes the hallux phalanges with it, right? And you've got that wandering great toe sign. Not always present. I think I've seen one or two of those cases like that. In a lot of cases, you just got that weird shape of the foot as you see it. Okay? Now, how do we grade those? Normal, valgus, mild, moderate, and severe. Okay? That is a good way for you to have a rudimentary assessment of metatarsus adductus, okay, metatarsus adductus. For your clinical practice, I would highly recommend to pay attention to this little chart. And just understand that if it's mild, it's bisecting the mid toe. Moderate, as it continues to get worse, then the foot tends to deviate more medially, right? You guys see that? Okay. You notice in the normal foot, a line bisecting the calcaneus actually goes through the second web space, right? Between the second and third toes. As it gets worse, it just continues to move further to the right. Plain films can be useful, but why subject the patient to so many plain films as you do serial assessment of this, right? Easy way is to just have mom take some photocopy of the patient's foot and then just collect it. It's fun for the kids because they like to see the nice, bright, shiny lights, and then they see their foot, printed on a piece of paper. It's just the dumbest thing, right? The things that amuse kids. It's incredible. Now, when do you refer to ortho? Refer when non-operative management fails, right? In most cases, not a whole lot that you need to do with this, right? But certainly have a low index of suspicion or low tolerance for referral. What can we do? If necessary, we can always place the patients in the flexible cast, right? Just to help correct things. Most cases, you just reassure the mom, hey, this is gonna actually pass as the kid continues to develop. Severe cases are the ones that you put in the cast. I cannot recall, and this is how rare this is, I think, having to do surgery on a young kid with metatarsal If it comes up, and the surgery is a choice for surgical correction. And you have my permission to raise your hand and say, sir, you did not cover this in this class. Okay, refer red flags if it's been 3 to 6 months and you see no changes, and or this is rigid and not correct. Let's talk about osteochondral defects of the talus. So, we talked about the talus being a significant weight-bearing bone in the foot. As a matter of fact, the talus during the push-off phase, right, or during the stance phase on any particular foot, is nearly 100%, right, of the body weight. Guys, remember this from day 1 or day 2, right? Remember, you've got the swing phase, that's the foot that is off the ground. You've got the stance phase, which is the foot that is planted as you walk, and so stands to reason that 100% of your body weight is in the foot that is on the ground, right? Okay. And the bone that really bears the brunt of that weight is the talus, right? Remember, as I talked to you about, you've got 50% distribution into the calcaneus, and then the other 50% is spanned out across the midfoot. Okay? Now, if during that phase you've got rotation about the ankle joint, then you can see why several portions of the talus might actually get bear a greater force than others. So if you're running and you're cutting left or cutting right, playing some sport, then you can understand why the lateral or the medial aspect of the talus can bear some additional weight. And so these osteochondral defects of the talus are usually due to repetitive motion in which you've got excessive forces on one aspect of the talus, right? That is usually on the lateral side of the talus. Right? And there have been some bilateral OCDs in some cases. I don't recall ever seeing that. It's possible. So, when you've got all of this denuding of the intra-articular cartilage, then what you have is you've got some avascularity, right? As the body tries to recoup and repair itself, right? You get collapse of the joint surface, and then eventually that little cap tends to just want to flake off, right? Now, oversimplifying this, it goes through a long process of inflammation and healing, etc. But the sense of it is that you've got repeated exposure, you've got repeated trauma, it denudes the cartilage, that little piece of bone tends to want to flake off eventually. Worst case scenario, it gets into the joint, now you have a bigger problem, right? So, before it gets to all that, if you can catch it early based on the patient's symptoms, because it will be painful for them, then that's the best case scenario. Right? There's a lot of things that we can do to help to alleviate those symptoms. Loose fragments in any joint, bad again. If you guys remember when you went through talking about the knee and meniscus tears, right? Better shake your head because the doubles is air spurt up, you're sitting at the back of the room. Not surprised if you didn't teach you this. I'm going to tell you about it right now. So, if you got a loose piece of cartilage in the joint, that's a bad idea, right? It's a bad thing. That you don't want that, right? Because it just causes more damage. Okay? Same thing in the ankle. And the ankle joint is even less forgiving because the intra-articular space in the ankle is much less than it is in the knee. Make sense? So loose fragments in the ankle joint are good. So patients may come in with symptoms of feeling that the ankle is giving way. They may have history of trauma, or they may not, right? Could be insidious. Say, I don't know what I did, it just continued. Every time I run, when I jump, I just have this weird pain in my ankle. Okay? Your physical exam should be no different from any of the other physical exams that we talked about. You watch the patient walk, okay? Watch how they weight there. You want to look at the extremity, the range of motion test, the palpation. In this case, when we talk ankle exams, and we cover this in the lab, you want to stress the ligaments. You should know your anatomy. You should know which ligaments lie where so you can know, and which bony prominences are in the ankle joint so you can directly palpate those, right? Remember what I told you? Visualize the anatomy under the skin, and you can get after the responses that you're looking for. Okay? Plain films may be helpful. Now, if you don't have a disruption of the normal anatomy, doesn't mean that you don't have the start of an OCD of increased stress in the talus. Okay? And so even if your plain film is negative, you should, and the patient is complaining of pain on the lateral or medial side of the talus, you should still be looking at whether or not they might be having an OCD. Okay. And we'll talk about what to do if your plain films are negative in a second. Now, earlier on we talked about having an AP and lateral of the ankle joint, right? Certainly an AP lateral of the foot, it's great, but remember on day one, I said if you want to visualize the entire ankle joint, what view should you get? Morse view, right? More than Mortise view, depending on which part of Texas you come, right? So, and what that does, it allows you to see or visualize the contour of the ankle joint. In that way, you can see the articular surface between the talofibular joint and the tibio-talar joint. Okay. Now, in some cases, acute lesions, there might just be something on the X-ray that doesn't look normal, right? in which you may not see like that smooth natural contour of the talus, and you know the radiologist might see it or may not, but as you look at your X-ray, if it looks fuzzy, in which there is a disruption of the cortex, then that should prompt you probably to get further studies. Bear in mind that when you look at your X-ray, in incidences of an OCD of the talus, there may be some inflammation that is deeper inside the structure of the talus and the substance of the talus. So what you see on the surface on X-ray, there is something else going down deeper inside. That's where your MRI comes in. And when you take an MRI of the talus, then you can get a better appreciation for the extent of the OCD. So again, even in cases where the natural contour of the talus is intact, you may see some actual disruption on the MRI as you see it. Here's a question for you. When we start talking fractures, we're going to get into the role of the CT scan in looking at things within the joint. Okay? Now, I want you to remember that if you want to appreciate the extent of an OCD, right, regardless of what we talk about in fractures, if you're looking at an OCD and you want to appreciate the extent of the OCD, in an X-ray that is equivocal, which means that you cannot tell exactly what it is, get an MRI. That is the study of choice. Okay? Could you get a bone scan for this? Right, the answer, sure. You get a bone scan for whatever you want, right? First thing you should do, right? And if you did, what would you expect to see on the bone scan? And a lot of things except the right answer. What would you expect to see on the bone scan? Would it be hot? Would it be cold? Would you see something there? Would there be nothing? Cold? Find Lee Passion and tell him that he taught you guys nothing in radiology. What do you think? No, I don't want to tell him the answer. Right? What would you expect to see on the bone scan? Yes, so she says increased uptake. Would you expect to see increased uptake on a bone scan in a patient with an OCD? Careful how you answer, because my next question is going to be why. What do you think? You're absolutely right. The answer is yes, right? So, you will get in, remember I told you, if I'm walking through here and I bump my knee on this thing, and I take a bone scan, it's going to show a pattern. It's very sensitive for inflammation. Man, we spend like 20 minutes talking about this and maybe not 20, maybe it's 5. Right? So, bone scan is very sensitive, but it's not specific. So you do a bone scan on this, if there's any other inflammation in there, it is going to light up, right? That's why for things like this, bone scan, if you want to say, yeah, maybe there's something going on, you want something to be more definitive, and then okay. What's the difference between the bone scan and the white blood cell, the TAC white blood cell scan? So what are you looking for? Infection, right? Why? They go to where the infection is. Not hard, right? Okay. Good. So an MRI will help you define the extent of the cartilaginous damage and subcondylar bone loss or bone injury. Okay. So, in a skeletally mature person, sometimes you can just allow it to heal, right? The one thing that you always do as part of your treatment, right? You can give some NSAIDs and do all that good stuff, but you have to stop the offending activity. So if they continue to run and jump and skip around with an OCD, right? OCD meaning osteochondral defect, right? Then this is not going to really heal. So you have to prevent them from doing that. And one way you can do that is, number one, stop the joint from moving, right? So you mobilize it. If it's severe enough, you could put it in a cast or a splint, but we have other things that you can use to do that, right? We have orthotic devices that you can use to help mobilize it. And when non-operative management fails, then you refer them for specialty care. Especially if they're getting to be a little older. What do we do when we see these things, right, in ortho? And and we used to have to cut the ankle open, back when I first started, and actually visualize this and drill it out and take a piece out, sometimes with a piece of a cadaver bone, fill the space, put some cement in, and they're good to go, right? Now we just get cameras, put a couple of portal holes in there, and do everything what we call arthroscopically, using cameras and a couple of ports. Our medicine has effects. But we can remove, if this is floating around, we can remove these and actually fill that void with some cartilaginous material. Okay. Questions or comments about that? All right. Take 5 minutes. Come back at a smaller tip. Yes, and the classmates. And do this during the next class. I think we far enough where we can catch up. Do you have any questions about what we just discussed? Okay. I understand some of you may not even know what you know right now to have a question to ask. That's okay. As you review this, and I know you've got endo tomorrow, once you pass that, right, I will ask your endo instructor to be nice. She's going to be, but once you pass this and you start reviewing this over the weekend, please do not wait until before the test to study for this test coming up. Okay. I think the other class did fairly well. There was only one failure in that test. But most of them, it took them over an hour to do. Okay? It includes a lot of things that we talked about here and some things that you talked with mixed doctors, right? But I promise you, at least 80% of what's on your test, I have talked about in this class. If you're asleep, can't help you. Now, if you're reviewing your notes from here and you have questions, you call me, okay? My phone is always on, just like my office is always open. I'm in there, right? Or text me, right? Don't send an email. I don't always check my email after hours. Okay? If you text me, I will respond. If you call me and I don't respond, I'll call you back. If you can't get a hold of me, call you without those. Okay? So you got 2 resources that you can use to help you through this. Test is very doable. And folks had high grades, some people not so great, but very doable. All right? You guys have a great rest of the day, and see you on Monday.